policy, and in the MPF document. So we know it's good for patients, it increases retention, decreases burnout. We'd be really interested to hear, Wes, about how you think we can change that culture in the NHS to really value research in the NHS, for example, with protected time for clinicians.
And that's an interesting idea, which we'll take away and think about. Just to say, like, I think we've got a total disconnection between the ambition of clinicians to take part in research, bearing in mind, the people who are doctors, some of the finest minds in the country. Don't they like telling me? But they are genuinely some of the finest minds in the country. And they want to be there for their patients, but they also are constantly thinking about, well, how can we deliver better care? What are the new treatments, the new technologies that can make a real difference? And we don't give them enough time. And I'm afraid, when it comes to clinical trials, we're going backwards on this. Participation in commercial clinical trials has fallen off a cliff, which means less innovation taking place in our country and also less income for the National Health Service. So a big part of my agenda is getting that research culture back and making it much easier for life sciences and medtech to work with the NHS as a partner through a single front door where they can test and trial new treatments and new technologies, and with the diversity of population we have in this country, so that the UK is at the front of the queue for adoption and rollout, but also so that they can then know that instead of having to, because this is how it works right at the moment, if you work with one NHS trust and you can prove your concept and get approval, you have to go and try and get through every other. I mean, we're not using the benefits of a single payer system in the National Health Service, and so just making these, it's not the sort of thing I'm afraid I can put on a leaflet because it's pretty technocratic, but my goodness, it make a real difference to patients if we get it right.
Everyone knows that doctors are failed political scientists. That lady, lady there.
I don't think that's true, sadly.
Hello, Sarah Wootton, Dignity in Dying. I've read your book and I was delighted to see you're a Star Trek fan. Is the end of life the final frontier for patient choice?
That's a great question. It's very close to my heart at the moment, having lost my grandmother on Friday evening after a pretty awful final 6 months of coming off life-extending treatment, which has given us 10 years with her that we never imagined we would have, to watching someone reach an inevitable and unnecessarily drawn out end. Now, actually, I don't know, because it's not the sort of conversation you would necessarily have in this circumstance, whether she would have chosen to exercise a right to die if it was available. But thinking about my other grandmother and watching her slowly die of lung cancer, I just, I still have burned into my memory the image of, my maternal grandmother dying on a hospice bed of lung cancer. And the difference between my two grandmothers is actually my grandmother who died on Friday actually was made really comfortable with what I would call really good, kind, caring, loving support from her local NHS trust, from Marie Curie nurses coming to attend overnight, and with drugs that meant actually, although she was dying slowly, she was dying comfortably and pretty painlessly. Contrast to my grandmother I lost when I was much younger, who died in excruciating agony and pain. I voted for assisted dying when it was last put before Parliament. I've got to say I've never agonised over a choice quite so much as that one, and I'm still not entirely sure I made the right choice. Because I think in principle, I don't mind the idea of someone exercising that choice. In practice, I worry about all the safeguards, the risk of coercion, the risk of pressure, either in deliberate pressure or unintended pressure. I think there are lots of moral, ethical and practical issues to work through, but I do think that it's so important we have this conversation, not just in the context of dignity in dying, but in terms of palliative care and how we die well and how we give people a great send-off. So I think as a country, it's always a taboo and it's very difficult, and particularly for me today, very raw to talk about. But I think being able to talk about death and giving someone a good death is such an important part of the public policy debate we should